Hello. Good morning, good afternoon, good evening, as may be the case wherever you are located. I am Madan Rehani, President, IOMP. I will be moderating this webinar. It's 4 a.m. for some who are in the Western zone of US and 11 p.m. for others in Australia. Thank you all for joining for this webinar. We already have 720 people and continuously the number is growing. We have a very distinguished speaker today, Professor Ehsan Samei. I will introduce him. Just a moment. Professor Samei has huge number of titles and accomplishments, as well as he is fellow of large number of organizations, as you see in the title line on the top. He is professor and chief medical physicist at Duke University. He is also director of the Center for Virtual Imaging Trials, which he established with the help of NIH project. He has authored more than 320 papers in peer-reviewed journals. He is very passionate about bridging the gap between scientific scholarship and clinical practice through virtual clinical trials, clinically relevant metrologies, and medical physics 3.0 program of FAAPM, which he has been chairing for some time now. He aims towards quantitative patient-centric use of imaging, effectual realization of translational research, and clinical processes that are based on evidence. I'm sure many of you know by this time that IOMP chose him to receive one of its most prestigious award, the Marie Curie Award, which will be given to him at the next World Congress in Singapore. The topic on which he is going to talk today to us is image quality monitoring, medical physics 3.0, and patient-centered care. Just as a matter of announcement, please keep your questions in question and answer box, Q&A box. Please do not add your questions in chat box. They will get misplaced, they will get lost. And another announcement that we always make recording available of the IOMP webinars on IOMP website within 24 hours of the event. With that, I pass on the floor to Professor Ehsan Samei. Ehsan, the floor is yours. You may please share your presentation.
I hope we can see my presentation okay, Madan. Well, it's a pleasure to be here. Thank you so much, Dr. Rehani, for inviting me to be part of this webinar series. It's an honor to be here, and I'm really delighted to be connecting with my colleagues across the globe on this very important topic. As Dr. Rehani mentioned, this topic is very close to my heart, talking about medical physics 3.0 and the relevance that it has in patient-centered care. First, I would like to thank you for attending this webinar. I know that all of us are many things that we can attend to, and you have chosen to attend to this particular talk. I'm honored to have you here. Also, I would like to acknowledge and thank my colleagues at Duke, at ACR, at the FAAPM, and at the NIH, who have essentially enabled me to work with them, and some of the work that I'm presenting here is part of the collaboration that I have had with those individuals. This is the outline that I will be covering today. First, I'm going to focus on MP 3.0, what it is, and the principle of patient-centered physics. And after that, I'm going to spend most of my time talking about the actual practice of patient-centered physics and imaging, and talking about three particular topics: metrology, targeting precision imaging, and monitoring precision imaging. And at the end, I have some concluding remarks. I also would like to highlight, even though I know that you have already attended this webinar, but some of the topics that I will be talking about today are also going to be covered at another webinar tomorrow at noon Eastern time, and is somewhat complementary to this talk because I will be focusing on some of the things that I would not be focusing today in my talk. So if you happen to be interested, you're welcome to join that webinar as well. It's Medical Physics 3.0 webinar tomorrow at noon Eastern time. So let's start with Medical Physics 3.0. Well, if you want to really understand Medical Physics 3.0, you first need to understand what medicine is all about. And I would say medicine at core is about discerning and intervening in the health state of the patient with sufficient accuracy, precision, and safety for definitive clinical outcome. So at the end, at the beginning and at the end, medicine is about the patient. This is such an obvious thing to say. But in reality, especially in the context of medical physics, we deal with a lot of technologies. The point here is that healthcare being about the patient and not particularity of the technologies, techniques should be oriented and valued to the extent that they benefit the patient. At the end of all of our games, being research game or practice game or clinical game or educational game, is a patient that's supposed to be the recipient of the goods that we produce. Is that possible? Well, not very easy. Because first, there are a number of realities on our way. Number one is clinical practice, which happens to be highly heterogeneous and variable across ever-expanding range of varying technologies that are implemented differently at different facilities, at different parts of the world. Even within a certain facility, there are heterogeneities of the technologies. And each one of these machines come with varying technological parameters. Of course, we have varying patients, varying human operators, and we have competing interests in that space. And that creates a sea of variability in the quality of care. If a patient walks into my facility versus your facility, they do not get the exact same care. Well, is that bad? Well, there was a report from Academy of Medicine, National Academy of Medicine in the US, that there is a cost to this variability. They state in their report in 2015 that most people will experience at least one diagnostic error in their lifetime. This is in the US only. I suspect this is even more in other places. 10% of patient deaths, 6 to 17% of hospital adverse events are due to diagnostic error. Again, I'm talking about the context of imaging. Imaging, that does not include only imaging, but imaging is a big part of diagnostic workup of a patient. And of course, there are malpractice lawsuits and so on that comes from that. So variability in the quality of the care can actually harm the patient. Well, at the same time also, healthcare is changing toward evidence-based medicine, implying practice informed by science, precision medicine, focusing on personalization of care in quantitative terms, comparative effectiveness, which it focuses on the actual utility as opposed to presumed utility of the technology, and value-based medicine, which is scrutiny on the stewardship, safety, quality, consistency, efficiency, and ethics of the process. And finally, there is a medical need, therefore. This is in this emerging landscape of scholarship, technology, and practice. There are new mandates for practice, new understanding of the disease, new technologies in reflection of the needs, and new needs calling for new applications. Call for innovation to meet the needs that I just highlighted. Here, then, we ask the question how physical sciences can and should add value in this landscape that I'm painting here in medicine. Well, we say physics is a foundational science governing nature that can speak to, well, general presence of science in medicine, what we call physics in medicine. We can speak to physical processes that inform health, whether it be physics of medicine, or more importantly than all of those, technology to meet the healthcare needs. That would be physics for medicine. So physics as a foundational science has a role to play in all the spaces that I described. So Medical Physics 3.0 is about fostering human health through innovation and precision of physics that only provided by physics, aimed toward patient-centered care. So physicists is to practice physics for the direct benefit of the patient, is a focus on the patient, either immediately in the clinical setting or eventually through research. We should never forget the fact that the patient is a recipient of our good. And if you really want to embody that, and I'm going to exemplify that in a few slides in a second, is a transformational extension from the insular practices of compliance and scholarship towards operational engagement and relevance. So this is the sort of the big definition of the field of medical physics 3.0. If you want to learn more, I have myself published a series of papers. The most recent one of those are in the January issue of the JACR, and another one is January issue of Physical Medical. I encourage you to look at it. There is actually a book on this very topic, but I'm going to highlight some of the things that those books talk about. In those books, we talk about this medical physics 3.0 embodies itself in 12 different domains of practice. This is primarily now I'm focusing on clinical practice. I don't have time in the time that we have together to go over all of those, but there are 3 specific topics that I would like to highlight and talk about how this philosophical picture that I'm painting would meet the reality of the clinical practice. So let's talk about practice of patient-centered physics in imaging. And that breaks down into 3 areas: metrology, targeting precision, and monitoring. So as far as metrology, I want to talk about metrology of dose and metrology of image quality. First, talk about dose for a second. So I just want to make this clear up front that patient exposure in imaging, any assessment of it, minimization of it, or optimization of it, is founded on one assumption, that radiation exposure imparts a non-negligible level of harm to patient. If we believe that radiation is just all good for you, then we don't have to necessarily quantify it. But if we quantify it, we are saying there is a potential harm. And while the magnitude of this harm has been questioned, rightly so, because there's many things that we don't know and debated, without a presumption of harm, patient exposure would be of no relevance. I just want to emphasize that. Also, in terms of image quality, we should remember, is a primary purpose of performing imaging in the first place. And what is image quality? Is collecting or needed information for effectual use. That's what image quality is. So while the image quality has largely been treated as subjective, you look at an image and say, oh, this is a good image or this is a bad image. Without quantification and management of it, the value of an imaging exam cannot be assured. And the third thing I want to mention here is that image quality and radiation dose go together, matter together. Less radiation can lead to dose levels compromising the image quality and the very purpose of the exam. For example, the image on the left is acquired at too low of a dose for you to be able to decipher that hypodense lesion in the liver. So you cannot just reduce dose. We have to balance these 2 things together. So this dose and quality needs collective management, technology assessment using metrology that matters. By saying matters, that means related to patient care. Applying those methods that target dose and quality goals prospectively, and then applying standards that curtails their variability retrospectively. So essentially it becomes a 3-fold aim. First, quantification of quality and safety, what I call precision by outcome in the context of technology assessment. Then targeting precision imaging by prescription, the prospective use optimization, if you will. And finally, monitoring and managing the variability through precision by outcome. So you first measure, then you figure out how you curate your imaging system to provide the measurements that you expect. And then at the end, you say, okay, did I get what I expected? So these 2, of course, these 3 inform one another. The first one can lead to the second one, so we have to do the technology assessment. And then the first and second together lead to the third one. And you see something in the third one, you have to go back and fix how you have acquired the images in the first place. So let's talk about each one of them in specific. So dose metric means good surrogates. Dose and quality can only be measured in terms of surrogates. I want to emphasize that. Surrogates are relevant to the extent that they relate to the essence that they are quantifying. If dose worth measuring, it should be related or relatable to patient risk. And if quality worth measuring, it should be related or relatable to diagnostic task. So let's talk about dose metrology. Ideally, we would like to know the actual patient risk. But we cannot get the patient risk directly. We cannot get our hands on it directly. So there is a spectrum of metrologies or metrics that we can use. We can use risk estimates that are not the actual risk, is the estimates of the risk. We can use organ dose estimates. We can do effective dose. We can do size-based dose outputs. We can use those outputs. We can even use device radiation output as a metrics of risk. So two exams, all things being equal, the one that has a higher MAS or higher flux or higher energy would have more dose, right? So all of them essentially are surrogates of risk. The ones on the left are simple, that's why we use them, but the relevance of them are inferred. The ones on the right are very complex, but they tend to be highly relevant. So we did a study to sort of compare various metrics of risk. And I want to highlight the work that was done by one of my colleagues, Francesco Ria, was published in European Radiology this last year, 2021. I can't believe it's already 2022. So you can think about along that spectrum from left to right, we are going from top to bottom in some ways here. There are risks that are related to indices of risk. CTDI, DLP, SSDE, in the context of CT. You could argue with me that DLP is the index of risk, but I would say, yeah, you were saying so, and I agree with you, but all things, if you don't have anything better, you use DLP as your index of risk, don't you? You say, this is a very high dose exam, look at the DLP, right? Or you can use effective dose, you can convert those numbers into effective dose, and there are different ways of doing this. You can compare, look at organ doses. You can also define one single organ, you can call it defining organ dose, and make that your metrics of dose. For example, for fluoroscopy, we use fluoroscopy skin dose, or for mammography, we use glandular dose as your metrics of primary metrics of dose. We can convert it to risk indices, which we have done, other people have done, or you can do a new metric that we have been advocating for, relative or risk-adjusted organ-based effective dose, which is essentially gets the organ dose and adjusted based on the risk that is involved. And in this study, we actually use a large cohort of patients. We match the patients to an atlas of virtual human models. And from those, then we can estimate organ doses for those patients. And if you want to learn more about this technology, I encourage you to go to our website and figure that out. So in this plot, I am showing you on the x-axis the risk index. On the y-axis, I am putting various metrics of risk in that previous slide. So if you look at the upper left one, here's CTDI as a function of index of risk index. And you see most metrics have very poor correlation with the actual risk to the patient. But that last one is probably has the closest correlation. We did this study across 9,000 CT exams that was, again, reported in the paper. And you see that different, for example, ages of the patients are as a function of risk on the x-axis. For a standard effective dose, lines up in different lines. But when we essentially incorporate the patient's sex and patient age into our estimate, they line up together. So essentially, we will have a singular metric that is more reflective, most reflective of the risk of the patient than any other metrics that we have. So why are we doing all this stuff? Because what I said in the beginning of my talk, it is at the end is about the patient. And if those worth measuring needs to be related to the risk of the patient, otherwise, why are we measuring something and trying to manage something that is not directly related to the very purpose of the safety of the exam? Let's talk about quality. Quality also falls within that spectrum. We want to know the actual quality, clinical quality of the exam. Is that possible? Well, we can't, We often do other things like clinical trials or case studies or virtual clinical trials, which I'm very passionate about. We can do animal models, we can do anthropomorphic models, we can do phantom measures and intrinsic specification of the system. Again, this is a spectrum. You could measure resolution. Is that the resolution clinical quality? No, somewhere in the middle of the spectrum. It's not. So again, we have the same paradigm here. The stuff on the left are simple and easy to measure, but the relevance of them are inferred, while the one on the right are very complex, but they are very relevant. So let me go back. One of the underlying problems with image quality that people rarely talk about. If you actually want to know what the actual image quality is, you should look at the ICRU report number 54. They beautifully define image quality in a patient-centric way, by the way. They say, is this the ability of the image to provide the needed information for its medical purpose or task? That definition, even though I totally agree with it, creates a significant problem in the way we quantify image quality. And what are the problems? Number one, it depends on the task. The problem is that we don't know the task ahead of time. Before I image the patient, I don't know I am looking for a 5mm lesion or 15mm lesion. If I don't know it, then I don't know what the image quality is. So even with known indication, for example, I'm looking for a liver lesion, the specific task associated with an image is not a priori known. The ground truth is not known even after the exam. So from case to case, actually image quality varies if you follow the ICRU definition per unknown varying tasks. There's a second problem with that definition. Image quality is in the eyes of the beholder. Image quality is at the discretion of the image reader, varying due to the intro and inter-reader variability. What does that do to us? It would make image quality only discernible by averages of reading across multiple images and multiple readers. So when you ask somebody like me or any image quality expert and say, what's the gold standard of image quality? We say, well, do an ROC study. A group of patient cases with abnormality, a group of patient cases without abnormality, and you discern the detectability across these cases. How many patient observers do I need to use? Well, 5, 6, 7, more the better. Well, at the end, what would I get? I get averages across 5 or 6 readers or observers, and across 50 cases of normals and 50 cases of abnormals. While image quality is assumed to be an attribute of an image, not an attribute of the cohorts of images. You see, that reader dependency creates a problem that we cannot define image quality for an individual case. So as a result, what we have done, we have used phantom image quality. We measure patient image quality in terms of using phantoms. But phantom image quality is not patient image quality. It's an alternative assessment due to its practicality and ability to systematically characterize varied imaging conditions. At best, it's relevant to only a single patient. A phantom is a single patient. Is an idealized model of image quality, not directly relatable to the individual patient cases. So here's an example. We have this mercury phantom, which has been advocated by TG233 to measure image quality in CT. We measure noise using that phantom across 3 different patient sizes. I put the patient size on the x-axis. I put the noise on the y-axis. I have GE scanner on the left. I have a Siemens scanner on the right. Well, as I change the diameter, the noise changes. And there's a difference between Siemens and GE. The point of this slide is not that they're different. The phantom shows me a relationship between noise and patient diameter. But in actual patients, you see a relationship like that, the actual noise in the patients. Now, the good news about this plot is that phantom seems to be providing a relevant reflection of what happens in the actual patients. The bad news is that it doesn't give you an exact replica. There is a variability involved. So what I'm building towards? I'm building towards the concept that we got to measure image quality on a case-by-case patient basis on actual patients. what I call case-based assessment of image quality. You measure image quality in terms of task generic indices, ascertaining the quality of informational representation offered by an imaging case in terms of image quality features, what I call in vivo indices. And then the beauty of that strategy is that you can combine those in vivo indices to reflect image quality across varying tasks, depending on what the task is. So what are these in vivo indices? There is a series of these. We are working with ACR on this to try to delineate what are the features, what are the ingredients. Like if you feel like you want to talk about different molecules of a particular compound. What are the ingredients of image quality? We know these are the things that we always know. Noise, sharpness, artifacts, contrast, and so on. These are measures of utility of a case to provide the desired ingredients, information, medical information applicable across ranges of potential tasks of relevance to the patient condition. So here's, for example, noise magnitude. We know the image on the left has a lower noise, the image on the right has higher noise. Here's a second example, noise texture. So on the left, the noise magnitude of these two images are exactly the same, by the way. The texture of the noise on the left is softer, the one on the right is harder. And here's an example of axial sharpness. It's a phantom image. On the one is a lower sharpness, on the left is a higher sharpness. These are ingredients. Doesn't tell you whether you can detect the lesion, but tells you what are the stuff that would represent or enable the image to render that particular task proficiently. So what's the value of this approach? Is a means to gauge the level of variability in practice, is a vehicle to improve consistency in practice, minimizing the likelihood of diagnostic error, is an essential ingredient to optimize dose and quality based on evidence, means to enable the best utility of new technologies, a means to measure and target value in value-based care. So why are we doing all this stuff? Because what I said at the beginning, because we want to make our image quality assessment relevant to the patient. Because at the end, all that we do is relevant to the patient. It doesn't matter how many line pairs per millimeter I am detecting. What matters is that, can I see the lesion? Can I relate those numbers to something that I will be able to see in that specific patient case? There have been studies out there that you actually can make these measurements on actual patients. These are some of the stuff that we have done in our group. We have demonstrated that you can make in vivo noise measurements, in vivo resolution measurements, in vivo contrast measurements, and in vivo perceptual quality. And I have put references there that you can check those out. So with that kind of approach, you could potentially form images or plots like this. On the left, I have the dose. In this case, is characterized in terms of SSDE, not the most patient-specific thing that I was mentioning, as a function of diameter for 3 different types of scanners. And on the right side, I have in vivo noise across different scanners as a function of patient diameter. You see there is a significant variability in that noise space, right? This is the real noise. This is not the noise of a phantom. If you have measured the noise of the phantom, you get only one line. The point is that though that one line is significantly underrepresented or undersampled the variability and heterogeneity that exists within the clinical environment. And we got to manage that heterogeneity because, as I mentioned earlier, that heterogeneity makes a difference. That variability has a cost that needs to be managed. So having done that, then you can now figure out, okay, how can I target exact precision of the images for the patient? Prospective targeting, if you will. Well, one approach would be starting with a phantom now. So we can measure the attributes of the phantom across those features that I mentioned, such as resolution, noise, and noise texture that I've demonstrated here. And then you can do illustrative and definitive processes such as the one that I'm showing here. This is a very complicated plot. Let me walk you through it. We went and measured resolution in terms of a scalar metric of resolution, in this case being average resolution, F50 of the modulation transfer function, if you will, across a series of CT kernels for GE and Siemens, two different manufacturers of CT scanners. I put the average resolution on the y-axis. I put the average noise texture, which is the average frequency of the noise power spectrum, on the x-axis. So the x-axis give me the noise texture, the y-axis give me the resolution, okay? And now I am seeing how different kernels of GE and Siemens relate to one another in terms of their ability to render resolution and their noise texture properties. So I can figure out which one is closest to which one. The colors, in case you might be wondering, is how much noise, how much dose I need to use in order to achieve a particular noise magnitude. As you can see, to achieve a particular noise magnitude of, let's say 10 in this case, 10 HU value, I need to use more dose for sharper kernels on the right side than the softer kernels on the left side. So I am essentially conditioning, by this analysis, I can conditioning the imaging system to render a specific resolution and noise that I am interested in. This is a demonstration of that approach in the new photon counting CT system that we just installed at Duke University. On the x-axis, I have all the kernels, reconstruction kernels, a majority of the reconstruction kernels that is available from Neutron Alpha photon counting CT system from Siemens on the x-axis. And I have the kernels from their non-photon counting CT system Force. And I'm showing you the closest TTF or resolution and noise properties across this kernel space. And on the right side, I'm demonstrating by essentially matching the resolution and noise, you can match the MTF and noise power spectrum. Why do we do this? We do that so I can figure out which one of the kernels that I'm showing you on the left that comes from photon counting matches the one on the right that comes from energy integrating. So by essentially ascertaining the inherent properties of how the imaging system renders image quality in terms of those in vivo metrics, I can condition my imaging system to render those data proficiently for a specific patient case. Having done that now, they can measure those attributes in the actual patients and see if we have achieved our goal. Retrospective targeting. So you can think about there are different attributes, as I mentioned, in vivo indices of quality, and the different attributes of safety. You can use, targeted organ that you're interested in or effective dose, and you can say, okay, I would like to have these ranges of the safety and these ranges of image quality in my clinical practice. Then I will consider my quality imaging practice to be proficient. It is like a strategy that we apply across any good that we acquire. So if I were to go and purchase a shirt, I don't want just the price of the shirt to be right. I want the shirt the color to be right, the fit to be right, the texture to be right, and also the price to be right, right? So all of those is to be right for me to essentially purchase that shirt. In the same way, if an image is supposed to be good, its resolution needs to be right, its noise needs to be right, its noise texture needs to be right, its dose needs to be right. All of the above together needs to be right for me to say this is a good image, and this is an image we've got to be acquiring at my facility. Let me demonstrate. I showed this plot already before. I'm showing you the dose on the y-axis and the size on the x-axis. So I can say, well, maybe the dose needs to be within the particular range. This is very similar to the concept of diagnostic reference level that we are applying across those anyway, as a function of size of the patient. That is no brainer here. But you can apply the same strategy for noise now. And this is for one particular type of exam, abdominal exam on the left, chest exam on the right. So you can apply constraints in order to achieve a targeted goal for a particular attribute of the image, for you to be able to manage, constrain, oversee, discern the level of variability and consistency in your imaging practice. Here is an example that we published also last year in Journal of Medical Imaging. There was a trial between Duke and Imagologics. We look at the noise, resolution, and dose across over 100,000 exams. And this happens to be a two-dimensional plot. I'm not showing you dose. I'm showing you resolution on one axis and noise on the other axis. This is a 95% representation of the data for one facility, all over the place. This is while the target maybe needs to be a particular area that we would like to have. So that facility fails to meet that target. This is a second facility. This is a third facility. You see, different facilities are able to manage their variability differently. But having those measurements, now I can gauge that space. And it's across all of them. So I'm coming to an end. I think, Madan, I'm keeping the time well, I think. Take-home points. So what is MP 3.0? Is, I would say, the new clinical realities that I highlighted on those quality checks at the beginning of my talk require, sorry about the typo, scientific and technological mindset of physicists to ensure and enhance quality, safety, and consistency of patient-centered imaging. In physics, we do quality control. I'm arguing that quality control needs to take a broader perspective to patient-centered care. We are not quality controlling just the machine. We are also quality controlling how the machines are used, and we are quality controlling the actual output of those machines, not in terms of phantom data, but also in terms of patient data. Extending from this insular practice of compliance, I check the box, I'm compliant, I'm good, and scholarship, towards operational engagement and relevance. So practice of medical physics 3.0 physicists is imaging dose and quality, we need to realize, are central to the very purpose of imaging. It's not something we do on the side. Remember, image quality is what imaging is all about. And what is dose and how they relate? We are dosing the patient to collect the needed information, which is image quality, for effectual care. That is the definition of imaging, by the way. And we are at the center of it. Physics and physics work is in the center of that space. Imaging dose and quality, though, need intentional management. First, we need to characterize them in terms of surrogates that matter, not just surrogates. Surrogates that matter. And what do I mean by matter? That means they're generalizable across and relatable to varying tasks in patient-centered care. So that's what patient-centered medical physics practice is all about. I can measure stuff that actually matter. Designing and prescribing protocols explicitly aimed towards needed dose for needed quality prospectively before we acquire the images, and then monitoring and assuring the achievement of those clinical goals retrospectively. So you can say, in a nutshell, we are moving from image gently, which I'm still supporting strongly, to imaging well and imaging consistently. So we got to not just doing gently, but also need to image well and image consistently. So with that, again, I would like to thank you for attending this talk. And I would like to again acknowledge colleagues who have helped me to think through some of the things that I described here today. Hopefully we have some time for questions and answers.
Thank you so much for this masterly presentation. As usual, it's really stimulating. It's exciting. Thank you indeed. We have a series of questions awaiting for you, and I will start with the first one. is from James Weston. He wants to know, to some extent, the pressure on providing the service support to medicine has meant that the split between the routine and the academic has grown. So the gap between academic and the routine. Should we patch up that up, or you are proposing we develop a new paradigm for connecting the two?
Yeah, I would say that we need to perpetually and continuously, great question, by the way, James. I think we need to perpetually and continuously revisit our priorities in the way we manage. I think some of those service requests and the expectations that people have is based on our desire to do better quality control of our imaging processes or clinical processes. I think we need to perpetually argue, I mean, to make a case that there are better ways to do quality control. In other words, it's not just doing more, rather to doing things more meaningfully. And I think if you do it right, that scholarship that is required is going to be part of the service. So in an MP 3.0 paradigm, we just get rid of the stuff that don't matter, so we can do the things that do matter. And the things that do matter, of course, need to be scholarly. So that's how they sort of those two can come together.
Thank you. Another question is from Shahid Khan about the diameter oblique risk correlation. Did it take into account BMI, fatty muscles in the patient as a variable?
It does not. Great question. I would say that that spectrum that I showed you, we got to be in the perpetual business of refining our metrologies, and our goal, our true north, if you will, is always about making it as patient specific as possible. So if I could bend in the sort of BMI or the fat content of the patient in my estimation, I will have a better estimate.
Thank you. Another question is from Prateek Kumar, asking as to how the risk in terms of number of deaths per 100 milligray was calculated, since death may not be easily attributable to managing those.
Well, those are come from Beer 7 data tables, and you could argue that they're not as best reliable as they should be, but I would say that's the best that we got. So science is about just using what you got. So for now, I think we're going to use those metrics as our risk metrics until we get better estimates. Unless we figure out there is no risk, in which case we don't do estimation of those. There are many other things we can do.
Right, thank you. Another question is from Alex Fernandez. Is it appropriate to compare the resultant noise and dose from two different CT scanners when the clinical protocols are different? So it may not be that appropriate without taking into account the protocols. And then further, he wants to know also what can be considered as a reference with regard to the protocol from different scanners when doing these comparisons.
That's a loaded question, which I wish I have a loaded answer to that question. I would argue with you that we got to think about it a different way. I think the protocol needs to be ordained so that we get consistent results out. So you could think about the job of a physicist to almost commodify the technology for the care of the patient. In other words, it should not matter if the patient walks into a GE room or a Siemens room. Our job is to measure the output of that imaging exercise in terms of metrics that are relatable to the task of discerning the disease of the patient, not whether this is not a Siemens disease or a GE disease, it's a patient disease. So, and that's exactly what medical physics comes in. If I have a comprehensive enough set of features that I can quantify that are related to the task, then the job of the protocol and job of the imaging system and job of the manufacturer is to best render those conditions in the best possible way. So our job essentially to change the protocol to get that. And then at the end, of course, verify that we got what we were targeting.
Thank you. Another question is from Ratiba Swabi about the cumulative dose, whether it is taken into account at some point for the safety following the number of scans the patient has undergone during the whole life. For example, not to exceed the predetermined acceptable level of the dose.
That's a loaded question, which I'm going to try to not to answer. I will encourage you. In fact, me and Dr. Rehani are leading a debate at the upcoming FAAPM meeting on that very topic, and I will encourage you to come to that debate.
Thank you.
No, and the short answer, though, no, we have not included cumulative dose in those estimates.
Hafiz Zin is saying, beside thanks, he is asking, the patient-centric approach is, of course, interesting, and the phantom usually are very well-defined parameters to for image quality metrics. Could you elaborate further on the general methods and approaches used to assess these image quality metrics using patient data?
I would encourage you for that to look at some of the references that are in my slide deck, which I understand the video would be made available. I think just we don't have time to go over those. Long and short of it is that we apply the same methodology, but as we're using for phantom in the patient, except that in the patient, you have to find a way to manage the variability of the estimate. The estimation is difficult because it's highly variable. You don't want your measurement to be an artifact of your measurement. You want the measurement to be the true reflection of that attribute in the image that you're characterizing, not the artifact of your measurement. So it's a little bit of an art involved in that process, and I would encourage you to look at our papers.
Thank you. Another question from Prateek Kumar is it's like the customization of image quality to the patient specific to the patient. At present, it is difficult to identify any quick parameter which may customize the imaging beforehand. Any comment on that issue?
I would say, again, we can, I still feel like it is perfectly fine to use phantom measurements as a measures of image quality. When I show that the spectrum, I'm not saying stuff on the left are bad and the one on the right are good. I'm just saying we need to understand the advantage and the disadvantage of whatever we use. But I will argue that if you don't have robust method to measure image quality in actual patients, the best thing you can do, if you measure those attributes, those features that I highlighted in patients, in phantoms, and at least try to extrapolate those measurements to what you might anticipate for a patient of different sizes for different tasks across your clinic.
Thank you. Another question from James Weston is, with the imaging systems becoming more of a black box, are we just fighting to quantify the performance of the system to pick up the least bad, rather than being able to drive back to the getting the images we want by being able to change or at least influence those who develop the algorithms and image processing, etc.?
I think that mindset is a good question. I would say the mindset got to change. In the past, in fact, when I started medical physics, I thought the job of acceptance testing is to figure out what systems are good and what systems are bad. I think that mindset is flawed because most manufacturers are not trying to make bad systems. So, and if you are just there to verify the specification of the system that this manufacturer is supposed to deliver, nobody wants to defraud you. Usually you're just verifying that the specifications are right. So you're wasting your time. I would say systems have different levels of quality. There is no question on that front. But the more important question is that given the quality that is given the features that the system provides, how can I condition the system to deliver consistent image quality for my patients? In other words, our job is not so much to acceptance of the machine, rather to commission the machine for commodified use of that technology for the best care of the patient. That's exactly what medical physics is all about.
Thank you. Another question from Hanif Haspi is how to compensate correctly between noise and resolution, because it seems they contradict each other in certain cases.
Yeah, sometimes you have to make hard calls, but most of the time you don't have to. Again, if you use my shirt analogy, you don't have to compensate between texture of the shirt and the color of your shirt. Just find something that has the right color and find something that has the right texture. So you could essentially, you can almost sidestep that question by saying, I need to have certain constraints for resolution and certain constraints for noise. As long as I stay within that sort of a sweet zone, I am fine.
Thank you. There is another question from Zohir Saga, a bit long one, so I will just read it as such. I thank you for the presentation that addresses the conflicts that still conflict, I think he wanted to write, conflict that still exists between having a good image quality with an optimal radiation cost or dose. I wonder about the scanner of the third generation that does not allow us to make a choice during the pediatric examination. What should be done to not irradiate the patient in order to have a CTDI that respects the diagnostic reference level?
So let me see if I can try to approach that question. I'm not sure I fully understand it, but I would say there is no such a thing as optimal radiation dose. There is no optimal dose. There is only optimal image quality. So the purpose of the imaging exam is to acquire the right information for the care of the patient, period. And in the process of doing so, you don't want to overexpose the patient. So the purpose is really get the right image quality at minimum dose. So I think if you target more on the image quality as what is needed, I would also say, let the dose fall where it may. I feel like we have put our dose almost, because we have not really focused on image quality, we are looking at dose as a poor surrogate of image quality. As a diagnostic reference level, we assume diagnostic reference level is a measure of image quality, but actually is a twisted way of actually being a measure of image quality, actually, indirectly, because we don't have a measure of image quality. But long and short, the goal is to get the image quality right, and then figure out what dose is needed and whether the needed dose is too much above what we are comfortable with.
Thank you. There is a question from Bill Broad Mogora that's in the absence of in vivo measurements, how can radiologists evaluate image quality? Something like A, B, C grade, is that useful?
I think so. So we have used, even in our facility, we use subjective grading of radiologists. I think it would be important, though, that if you can inject more science into that process, in that you already alluded to that, have A, B, and C, maybe some degree of grading that can be applied. And you could use that, but somehow that measurement, because that's a measurement, it's a bad measurement, by the way, because it's highly variable. If you do it in the morning or in the afternoon, you might get different results. But it's a measurement nonetheless. It's important to establish a relationship between that measurement and the measurements that you will generate or collect from phantom images, because you got to interpolate, or rather extrapolate, from phantom measurements to what the radiologist would expect. If you can make that connection, then you have a calibrated phantom measurements that you can use for additional refinements.
James Weston is commenting on, or rather complimenting the answer which you gave to his first question. He says, totally agree that we do need to do the right thing, not just what we have been able to do in the past. Engineers can do QC now better than I can.
Yes, thank you. Appreciate that.
Anonymous attendee, are these in vivo quality measurements being evaluated by radiologists?
We have ourselves, it was not in the list of publications that I included, but I can provide that. But we have done 3 or 4 studies that correlated those measurements with radiologist performance in not just subjective performance. We have also done that, but also actually objective performance of detection. And there seems to be a strong correlation between the two. And there is no surprise there, because where did resolution and noise and contrast concept came from? Well, it came from psychophysical studies. So we are essentially reaffirming the science that we have always known.
Thank you. There is a question by Hameed Abdullahi. How virtual clinical trials are patient-centered?
I would encourage you to attend my webinar on virtual clinical trials. That's going to happen in the first week of March, I think, by the FAAPM. But the short answer of that is that virtual clinical trial is yet another methodological tool at our disposal through which we could create anthropomorphic phantoms, models of the humans that are similar somewhat, it's in the middle of that spectrum. In fact, I demonstrate in the middle of the spectrum, that can be a little bit more patient specific than the more of a plasticky phantom that we have used in the past. And that can maybe shift us a little bit toward the right side of the spectrum, short of doing the actual clinical trial.
Thank you. A question by Richard Mitash. Did you combine the different feature attributes of an image in any way to get one statement about image quality, which can be compared with the corresponding dose, something like a scoring, for example?
Yes, yes. So there are a series of models, we call them observer models, that combine these task generic metrics into task-specific performance, like detectability and estimability, is analogous to effective dose. You have different organ doses that combine them together with some weighting function into effective dose, is that. And in fact, that the study that I alluded to just a couple of questions ago was such a study. We combined them into an observer model. We measure detectability that way. And then we also measure the detectability from radiologists reading the cases, and then look at how the two are correlated.
Thank you. We have still more questions than the time we have, only 1 or 2 minutes left. I will quickly go in sequence. The first one on the top in my list is the in vivo indices approach needs very large cohort. And this is a question from Perrin Tilsky. What cohort size do you recommend? How do you process so much data?
We have done between hundreds to thousands. So right now we're in hundreds of thousands of cases that we have run. I think if you are in the hundreds, you probably can get a reasonable sample of what you have in your data set.
Thank you. I mean, I see a huge number of questions still in the list, so I think this may be perhaps the last or second last by Massimo Lano Porzio. How do you all those measurements on patient images without resources from our employers? We have lack of time, software, etc. How to achieve the measurements on patients?
Yeah, so this is not a software package right now you can go and purchase. I recognize this is supposed to be somewhat of a futuristic talk. So I am actively working with some other colleagues to try to see some of these resources can be made available to the international community. I've been talking to IAEA, to European Union, to see if there would be pathway to make some of these resources available. I totally agree. But I just want to make sure we all understand where we need to go in the field of medical physics.
Thank you. I think we will have to stop here, unfortunately, although there are very many interesting questions, but we need to respect the time. And I wish to thank you, Ehsan, for the great presentation and attending to so many questions. This has been a wonderful session. I'm sure the participants must have been really benefited. I will now go over to the announcement of the next webinar.
Pleasure to be with you. Thank you so much, Madan. And thank you for great questions. Sorry, I was very short in my questions because short answers because there are too many questions.
No, you did a great job. Thank you. So the next webinar will be on Tuesday, March 22nd. This will be slightly different time. Normally we have 12 noon GMT, but the speaker is from a country and a location where it means 11 p.m. for her. So we wanted to make her a little comfortable. So 1 hour before. Biologically targeted radiotherapy utilizing imaging biomarkers to characterize tumor heterogeneity for precision radiation therapy. And it will be presented by Annette Howard, and moderator will be Eva Bizek. With that, I wish to thank all of you for your participation, for your questioning, and I wish you nice rest of the day or nice evening. Stay tuned. As indicated in the beginning, we will send the certificates automatically within the coming 48 hours to all those who attended in full. And if there is any person who does not get, please send an email to iomp.meetings@gmail.com. So this is the slide which you can look at, iomp.meetings@gmail.com. With that, thank you so much. And I will now close this webinar. Bye.
Thank you.
Thanks to
Bye.
Magdalena.